My name is Mike Mathis. I'm a cardiac anesthesiologist at the University of Michigan, and I'm an advocate for the Early Stage Anesthesia Scholars Group. Just a quick plug for those who don't know. This is a group of young anesthesia, academic anesthesia aspiring academicians that are having a programming actually going on right now for kind of speaking to developing a career, an early stage career in academic anesthesia. These lectures are actually happening right now, and although it's a bit unfortunate to have scheduling overlap with this talk, competing with George Mashore downstairs. If you didn't know that, forget I mentioned that, just disregard that. But I'm excited to give this talk, support the eSAS program. So if you haven't heard of us, just Google our name and consider joining us today. So my disclosures include grant support through the NIH and through the Department of Defense. Also, I'm an anesthesiologist at the University of Michigan, which happens to be the coordinating center for the multi-center perioperative outcomes group, which will be a significant component of this talk, so I offer that disclosure as well. So the goals of this panel are to make a case for why it's not just a good idea for anesthesiologist researchers to collaborate with others outside of their department in order to pursue interesting and impactful research, but it's actually critical for anesthesiologists to do this if they're to make a sustained and meaningful public health impact. And what I want to do today is describe who these collaborations could be with, how they can work, and why they're useful. And then wearing the hat of an eSAS advocate, I want to frame this in the context of developing an academic career. I'm joined by my colleagues, Rob Schoenberger and Shams Akhtar from Yale University, and they'll be sharing their complementary experiences. We'll be taking questions at the end of the panel, just in the interest of time. So the core questions to explore in this panel are, what is the public health relevance of anesthesiology, and what can we do to maintain and improve our public health relevance? And in putting this together, one way to conceptualize this is to understand the priorities of a health research agency that inspects the public health relevance of every project that it funds, and that's the NIH. Back in 2016, the NIH unveiled an institution-wide 5-year strategic plan that had 4 core goals. They wanted to improve health treatment and prevention. They wanted to recognize the value of new approaches to old problems through fostering innovation. They wanted to promote continuous peer review and steps to enhance the rigor and reproducibility of science and studying the science of science. And then, as especially relevant to this panel, they have a goal of enhancing scientific stewardship through promoting the collaborations of a diverse and talented biomedical research workforce. So within this conceptual model, we need to consider, where do anesthesiologists fit in? And to work on an answer to this question, it's helpful to first consider how we are perceived by health researchers who aren't anesthesiologists. There's good, and there's also there's positive things about anesthesiologists. There's also some negative perceptions of anesthesiologists. I'll start with the good. One thing that an anesthesiologist is recognized for is our extensive knowledge of cardiovascular physiology and pharmacology, and we're recognized as being excellent physicians for taking care of patients who are critically ill, either in the OR or the ICU. Another good viewpoint of anesthesiologists is their extensive knowledge of acute and chronic pain management. And we have an opportunity to lead incentives to combat the opioid epidemic, which dominates many of the healthcare headlines today. There's also some negative things about negative perceptions of what anesthesiologists are. And one thing I'd like to start with is, among patients with chronic diseases, many providers are involved in a patient's longitudinal medical care and can be continuously involved. But the perioperative period sometimes is a fleeting moment in the patient's chronic health trajectory. And anesthesiologists, whether this is perceived or real, will often have a limited opportunity to make a sustained, ongoing health impact in a patient's chronic disease trajectory. Another negative perception is that although anesthesiologists are the leaders in patient safety, And when we consider the spectrum of surgical outcomes, anesthesia complications are almost never events, and that's great. But you could argue then that we've conquered this mountain decades ago, and you might ask what more needs to be done. This is a problem that's essentially solved. And there's also the ugly. That's the kind of the character portrayal of us on the big screen. I think in the history of TV and movie dramas, we have yet to have a positive character portrayal of us. It'd be great to have just one time when there's some positive anesthesiologist, but we rarely see that in TV or movies. So how can we improve our public perception and create greater impact along the health research pipeline? Well, where we could start is to break down our thinking about how we commonly classify health research. And one way to do this is through the translational research spectrum. The National Center for Advancing Translational Sciences defines this as discrete stages ranging from T0 to T4, where we start at T0, which is the kind of the basic science drug discovery stage. We go on to preclinical studies, first in human studies at T1, T2 being phase 2 and phase 3 clinical trials in patients, and then we disseminate those findings to implementation, research, and quality improvement in T3. And then finally, in the community and at scale, we look at population health outcomes at the T4 level. In IARS meetings and other anesthesia meetings, traditionally we'll emphasize classifying research along this spectrum. But another way to think about health research is to classify by specific health disciplines. And although anesthesiologists do well to cover the translational research spectrum, we don't always do as well to penetrate across health disciplines. We often stick to our home in the hospital, sometimes reaching out to other specialties within the medical school, but often we neglect reaching out to outside the medical school. And we can deprive ourselves of opportunities to advance our field through collaborations with these other important health researchers. So what health disciplines are primed for collaboration with anesthesiology? You could actually argue that this is essentially any health discipline, but ones that at least seem to stand out to me and are in part discussed in this panel include those within the medical school, including surgeons, primary care physicians, cardiologists, psychiatrists, neurologists, and PM&R kind of in the pain realms. And beyond the medical school, there's opportunities for collaboration with data scientists, computational bioinformaticists in the School of Public Health, Epidemiology, Health Policy, and also the School of Pharmacy. There's certainly low-hanging fruit in each of these that we could take advantage of as anesthesiologists, and these are primed for collaboration. How do we do this? There's very simple things. We can attend local meetings within our own hospital, attending multidisciplinary core conferences, clinical practice committees. At a regional and national level, we could actually attend meetings outside of our specialty. Again, other ways to reach out to non-anesthesiologists, health researchers is through seminars. Sometimes institutions have specific collaboration spaces designed for this, and I'll talk about one that I've joined at the University of Michigan that's been transformative for my early career. And then we can also do this through discrete projects. So sometimes collaboration can happen more easily if channeling efforts through a specific and tangible research project or grant, if we're able to align that with the priorities of the funding agencies. So within this framework, and in parallel with my colleagues on this panel, I want to share some of my humble thoughts and experiences that these collaborations can have on augmenting research impact and making for a more satisfying academic career. So in my own career, there's been two groups that have had a great impact on my work and approach to health problems, and those have been data scientists and surgeons. So we'll focus on each of these two groups sequentially. So starting with how data science has touched my work, this story begins with the inception and the growth of EMPOD, led by my own career mentors, Dr. Sachin Ketterpal and Nirav Shah. It's a group, it's a consortium of perioperative electronic health records across over 50 hospitals, a group that started over a decade ago when I was a resident and is now growing rapidly across major medical, academic medical centers and private practices. Looks like we need probably one institution, either Idaho, Nevada, or Arizona, to get a coast-to-coast span. So we're getting there. But through developing this collaborative and attempting to harness electronic health record data, we've come across many challenges. And the two major obstacles that we've come across are, one, understanding health EHR data. It's, as we all know, very messy. There can be issues with incomplete data. There can be issues with redundant data. How do we reconcile two different blood pressures, one from an A-line versus a non-invasive if we're going to do some outcomes research study? There's often conflicting data, and there's also sometimes just flat-out inaccurate data. So we need to be able to screen out artifact within the electronic health record to do accurate analyses and not incentivize misguided practices. There's also a challenge to implementing, and it's very challenging. It's one thing to create knowledge. It's another thing to disseminate knowledge and invoke change. And so there's a saying in bioinformatics that informatics is 10% medicine, 10% technology, and 80% just getting people on the same page, agreeing what are the best practices and what can we do to achieve these best practices. And so I'll start with the first obstacle of understanding electronic health record data. We all know that more data isn't better if we don't have a way to digest it. And so taking on the challenge of putting big data to work, one of the best things that Sachin has done for me as a career mentor is to introduce me to a collaborative group of not only clinicians, but faculty from the schools of engineering, computational bioinformatics, public health, and epidemiology. This group at University of Michigan is called the MyChamp Group, the Michigan Integrated Center for Health Analytics and Medical Prediction. And through grant funding has been able to form a community for sharing ideas and gaining valuable multidisciplinary insights on whatever specific project you're working on. So this is what the group looks like, and I've been very humbled to be a part of this group. The information exchange that I've found goes between clinicians and data scientists goes a little bit like this. The clinicians and the data scientists, they each have their superpower and their weakness. On the clinician side, our strength is we understand the clinical problem. We take care of patients day in, day out, and we truly understand the nuances about a specific patient in front of us that makes them different from a typical patient or the population of patients at large. And so we understand the nuances about a specific patient and truly understand the clinical problem. Our weakness when we talk to data scientists is that we often fail to codify judgments and assessments into terms that are discoverable within big data. So for example, a clinician might say, oh, this disease process only happens in children, and then a data scientist would counter with, okay, well, what do you mean by children? Do you mean toddlers? Do you mean teenagers? Do you mean 0 to 18 years? There's a level of specificity that a data scientist demands when trying to analyze data, big data. So it's something that clinicians, I've had to work on myself as a clinician, but it's certainly been transformative in my thinking when launching into a project looking at electronic EHR data. The data scientists, on the other hand, they do know how to handle big data, and they know the best ways to solve problems regarding missing data or inaccurate data, and they have very nuanced methods for handling issues with the data available. But their weakness can often be that they focus on the wrong details, or they lack access to the right data set, or they sometimes just have an issue with access and sometimes have an issue with understanding the nuances of the clinical context in which the care was provided. So there's an opportunity to collaborate here, and it's been certainly a very fun, rewarding part of my early career. Although clinicians and data scientists seem to have kind of a complementary skill sets, they're often impeded by the same common problem, which is access to data. So clinicians will, perioperative electronic health data, it needs to be available to both clinicians who aren't usually fluent in any programming language, SQL, Python, Java, or R, and it also needs to be accessible to data scientists who aren't usually a first-degree relative of their hospital CMIO, which is often needed to access their data. So this is an issue that we've taken on within our own EMPOD group, and through working with clinician researchers and data scientists to get access to relevant health data in a self-serve fashion, we've been able to develop this tool called EMPOD Data Direct, with the goal of democratizing access to data so that you're spending not 80% of your effort just getting access and 20% of your effort doing the analysis that you intended to do, but actually the opposite. So it starts with an intuitive data browsing tool with broad categories, and then it drills down into nitty-gritty detail. So you could select specific comorbidities or specific diagnoses, specific physiologic data that you might be interested in. And you can drill down to specific details when you're creating a cohort of patients that you wish to research. And then finally, once you drill down through this tool, you can develop very quickly specific cohorts to see if your project is even feasible, and if so, you can get access to the data in a very, very quick, rapid form. So I'm just going to walk through. I guess the font is a little bit small here, but just hypothetically, what I was able to do here in about a minute is create a query for looking at EMPOD data for how many adult females undergoing a non-cardiac elective surgery of general anesthesia that had a specific set of comorbidities, hypertension, diabetes, and renal insufficiency, received propofol during the surgery. So this is just a hypothetical example, but we can very quickly figure out how many institutions, how many cases are in this cohort, and we can decide if a specific research project is feasible, and if so, with proper data use agreements in place, IRB approval, and with approval by the research committee that we've created in which all institutions participate that are a part of EMPOD, you can access this data in a secure enclave in a format that's interpretable by a clinician who may not be necessarily a data scientist that has unique skill sets handling specific programming languages. So once working to get access to this, to democratize this access to data and pointing to which variables which we believe as clinicians are important, we've been able to get a tidal wave of feedback from data scientists and been able to, and their feedback has been to focus on ways to improve the quality of our analyses. And some of the tools that are kind of being developed very, very rapidly now include natural language processing, so taking unstructured medical text in a perioperative, history and physical, or the intraoperative record even, and turning that into structured data. Machine learning, so developing complex algorithms to predict outcomes, and then waveform processing, so it's another untapped, or largely untapped resource that's when getting this into the hands of data scientists, we can do some really, really great work. And so through this give and take of skills and insights, we're moving forward with some potentially very impactful projects that neither group would be able to conceive or accomplish on their own. And to illustrate how this can work, I'd like to highlight just one example of my own work, which draws from this collaboration. And this is a machine learning model for improving the diagnosis of heart failure using perioperative data. And heart failure is a diagnosis that we know is uniquely amenable to machine learning in that it usually is based on a constellation of symptoms and test results. And often this data is kind of buried in different locations within the electronic health record. And so often the diagnosis of heart failure could have been made early on if a clinician had had the time and resources to fully review records during each healthcare encounter. It's not a reflection on the quality of the review by the clinicians, it's a reflection of the reality of a busy clinic schedule, and that there's opportunities here for a machine learning algorithm to help improve the diagnosis of early stage heart failure. So this leverages, you can use perioperative data, which is very granular, and it's an index opportunity to improve the diagnosis of heart failure. And the goal would be to actually embed a heart failure sniffer directly into the EHR that could alert a physician about the patient's likelihood of having heart failure. And so if this was done to perfection, what this could look like is we take a patient having surgery, and we examine both the preoperative electronic health data, including a preoperative history and physical, laboratory values and testing. And we also examine intraoperative data containing physiologic responses to surgical interventions, surgical incision, or even anesthesia interventions such as intubation. We can use this data in a novel and intelligent way to infer a patient's probability of having early stage undiagnosed heart failure. And if this probability of heart failure exceeded some pre-specified adjustable threshold, we could initiate a referral for further evaluation to a collaborative team of anesthesiologists who could adjudicate the preoperative and intraoperative data that was used by the heart failure prediction algorithm, and then potentially, if deemed high enough risk of having heart failure, we'd initiate a cardiologist referral who could then initiate life-extending medical therapies and establish long-term follow-up with patients following their surgery. And so reflecting on this collaboration and wearing my eSAS hat, I'll say this collaboration's had a profound impact on my academic career. It's established relationships outside of the medical school, and it's been a source for K-grant funding for me. And it's been the launchpad for multiple future research projects. The next major collaboration opportunity I've had in my career has been with surgeons. And where this collaboration has taken place has been outside of the OR, through participation in patient safety organizations, which are legally secure environments where clinicians can voluntarily report and analyze data with the goal of reducing risks associated with patient care. In Michigan, as funded by Blue Cross and Blue Shield, these are called collaborative quality initiatives, and we have 17 different health quality improvement programs across many of the major surgical and anesthesia subspecialties. And through site visits and quarterly statewide meetings, these collaborative quality initiatives have enabled clinicians to work together to solve problems around variations in outcomes explained just by variation in practice patterns. And through these meetings, we can achieve the goal of learning from top performers and disseminating best practices. Through these meetings, what we've come to recognize is that there are two key prerequisites for decision-making based on quality improvement data. One is the need for high-quality process of care measures, without which we'd be failing to capture the variation that we would need to understand to drive best practices. And we need high-quality outcome definitions, without which we'd be potentially incentivizing misguided practices. So where do we collect this quality improvement data? There's multiple sources, each with their own strengths and weaknesses. Anesthesiologists studying perioperative electronic health records often get their data from administrative data, which has the advantage of being rapidly available, easily scalable, but again has a downside of being often charted by a billing specialist who's not a clinician, and oftentimes there's limited accuracy with administrative data. There's laboratory and testing values, which again are also very easily available, scalable, and they have, and that's great. There's a disadvantage, of course, of not all outcomes are easily defined by a specific lab or test result. There's the intraoperative record, which is unique to anesthesiologists studying electronic health records. They have the advantage of being objective. You can have very highly granular data on physiologic observations, fluids, ventilator settings, medications. And so these three have been developed very well through an anesthesiologist's electronic health record infrastructure such as EMPOD. And a fourth source for information generated to affect quality improvement are from surgical outcome registries. This is through manual review of the electronic health record and patient follow-up. This is very high quality, but can be very expensive and very, very time-consuming. One example of a outcomes registry is the Society of Thoracic Surgeons Surgical Outcomes Registry. They hand review and hand enter this data by a trained nurse specialist that includes 30-day postoperative follow-up. And it has very rigorous, very trustworthy data definitions. And so what we've come to realize is that data access for quality improvement measures for an anesthesia collaborative is often complementary to data accessed by surgical collaboratives. And so there's an opportunity to share data. Within our MPOD group, we've been able to take our information on administrative data, lab values, physiologic testing, observations within the intraoperative record, and we've been able to combine these high-quality process of care data with high-quality outcomes data available through surgical registries. And we've been able to develop new lines of research through integrating these two into one central repository. We've been able to develop different research projects that have been not otherwise been able to be achieved by one data set alone. So one example of this is a study that we did looking at the impact of tidal volume as available within anesthesiologist's intraoperative record and outcomes, pulmonary complications after thoracic surgery using the STS Surgical Outcomes Registry. And so reflecting on this collaboration, and again wearing my eSAS hat, this has also had a significant impact on my own academic career. It's created a powerful new data set. It's extended intraoperative partnerships to new research projects, leading to potentially multiple R01 grant submissions. And it's really been fun to work with those that I work with across the drapes in the OR, outside of the OR, and develop new research and quality improvement opportunities. So it's the satisfaction of engaging a community of both surgeons and anesthesiologists at these quarterly quality improvement meetings has been very, very satisfying for me. So with that, I will end my talk, and I will introduce, I'll let Dr. Robert show.